Chapter 31, Section 3, Diphtheria and Pertussis. Okay, so we're looking here at different airway infections, okay, upper and lower respiratory infections. Diphtheria is actually a very severe respiratory disease that infects small children, okay, 1 to 2 years of age up till about, I believe it's like 7 or 8. Don't quote me on those ages though. Diphtheria is going to be caused by the bacterium known as Corneobacterium diphtheriae. The disease name, species name. A lot of times they're tied together. This is a bacteria that forms irregular rods. Okay, so its shape is very distinctive. Unfortunately, even though it is a severe disease that infects quite a few children, it is easily preventable. There is a vaccine for it. And thankfully, as we're getting better with this, identifying it, coming up with prevention treatments, we're also getting post-infection treatments are actually also getting better. When you look at a slide of Corneobacterium diphtheriae, you notice it does take on these club shapes. So it is not a cocci, it's not a bacilli. It takes on these weird atypical, or it's typical, but it's atypical against other bacterium shapes. So this is a characteristic. If you're ever in a clinical lab and they're like, oh, hey, look, I just did this Gram stain or this, methylene blue stain of this bacteria. Look at the weird shape it has. This, ding, 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 indicates diphtheria. If you see it growing on an auger, it needs special. Okay, this is one of those that needs, it's very fastidious. It needs enrichment. So it needs to grow on blood agar with an additive known as tellurite. Not blood agar or blood agar with a tellurite. This is going to have very difficult growth. Spreads by airborne. I cough. You breathe in what I just coughed. Enters the body via the respiratory route. That's what they're talking about. Previous infection and or immunization does provide some resistance. Doesn't mean you are bulletproof anymore. Okay, it just means that your immune system is going to be able to respond faster and be able to catch the infection before it begins to spread, before it gets to do damage, before it gets to the point that the toxins can be released and go systemic. Remember, got that toxemia we have to worry about. What you have to be careful of is the fact that some of the strains of Corneobacterium diphtheriae have or are carrying a bacteriophage. Okay, these bacteria are lysogenic right now. They have a bacteriophage that has transformed them, is giving them a new exotoxin, a new ability. This exotoxin causes what is known as a pseudo membrane. Okay, we've talked biofilms and things like that. So it's kind of a biofilm, but it's not a mixed culture. It's going to be Corneobacterium diphtheriae. They're going to be doing damage to the tissues underlying or that they're attached to. And basically, it's going to wall off part of the throat, part of the airway, part of an alveoli sac. Young patient here. You see the inflammation around the throat causing everything to swell, which automatically makes things a little more difficult. But you look here behind the uvula, in the nasopharynx, you see this white growth here. This is what I was talking about, that pseudomembrane. This is a covering, a proteinaceous, bacterial-derived covering of the bacteria that are growing there, and it's just walling itself off. Tissues underlying it are being damaged, causing more inflammation, causing more release of more fluids, more stuff, more things for the bacteria to grow in, eat, absorb, utilize, and more membrane to be laid down. This takes what's already a narrow passage for the breathing of a child and just makes it smaller and smaller between the inflammatory response. See the swelling under the neck and around, under the jaw and around the neck is already collapsing it down a bit, and then you get that pseudo membrane. It's making it harder and harder. So think about it. Next time you're out eating, take the straw. Yeah, you can breathe for a while. It's going to be hard. You're going to get a little lightheaded after a while. You're going to have to work at it. You're going to have to concentrate it on it harder. Same thing with these patients. Can be done, yes, but it's going to be hard, and it's going to become more difficult as this spreads, gets larger, more inflammation, and so on. Diagnosis, well, basically a throat swab. You look for those barbell-shaped bacteria. Appearance of that pseudomembrane, and that's not, boom, stamp of approval right there. We've now proven it on its own. You have to see the pseudomembrane because they may or may not always be present, but the final, final hit on the nail, crap, can't think of my analogies today, keep getting them mixed up. The final piece de resistance is when you go through and you do the slide, you stain the slide and you see those barbell-shaped bacteria. That indicative, yes. Presence of pseudomembrane, good, but that may not always be present or may not always be in a place where it is visible. Prevention, well, it turns out that there is a vaccine cocktail. Diphtheria, tetanus, and pertussis. Call it the DTaP or DTP or TAP, depending upon where you're at in the country and how it kind of way they want to call the acronym. But this is for small children. I think it's like 1 or 2 years of age. And that should get them through childhood. The tetanus is one they're going to redo as you get older, but this should be well enough to get you through any diphtheria or pertussis exposure. Treatment, if they already have the diphtheria, antibiotics. Get rid of the bacteria. If you're starting to see that it has advanced enough, the jaw, throat areas are swelling, and you see the pseudomembrane, then you come in with an antitoxin. This is going to be antibodies to the diphtheria toxin. Remember that beta toxin from the lysogenic bacteriophage. This is basically just antibodies. The toxin was injected into either another person or somebody who's already survived it. They took their antibodies, which is costly, or they injected into a rat, a mouse, or a horse. Pieces of the toxin. They made antibodies to it. We isolated from that animal, and then we inject it into you. You only can do this once or twice before the immune system starts responding too quickly to the horse antibodies, rabbit antibodies, or whatnot. But this is usually a one and done type of give the injection, and this will bind up the toxin so that your immune system can remove the toxin. And if the toxin's what they call opsonized, covered in antibodies, it can't bind to any of your cells. It can't do damage. The other we're going to be looking at here is pertussis, also commonly referred to as whooping cough. Why do they call it whooping cough? Because that's literally what the cough sounds like. Whoof, whoof, whoof. Which for me, that sounds kind of funny because, I'm a 50-year-old man doing that. When you've got a little infant, a baby, or some child that's 1 or 2 years of age, and they're making that whoof, whoof, cough that's coming from deep in their chest, it gets a little bit more Bordetella pertussis, causative agent here. Frequently, as it says there, school-age children. So about 1 or 2 years of age, again, up to 7, 8, 9-ish. Don't quote me on the ages, okay? I'm just going off of what I've read many different places. The age brackets can move, slide a bit. So it's this, one of the chief symptoms of this is that big, deep cough coming from a small little body. Okay, because of the bacterial infection, they're trying to get it up out of their lungs. That's their body trying to do a deep cough. Problem is they can't get enough air in and enough air movement out to get a really good cough. So it comes off of this cough. We've seen this trend upwards since the 80s. Don't know why. That's one of the things. They think the correlation here is parents aren't getting all of their children vaccinated. Because remember the vaccine we just talked about with diphtheria? Well, pertussis was one of. Diphtheria, pertussis, and tetanus. Well, they always get the tetanus individually. They don't always get the pertussis, diphtheria along with it. Don't know why. You can see this in older children and adolescents, some adults, if they are inadequately immunized or they're being exposed, recurrent exposure, and they just don't have a really good immune system. That's another area we're looking at. So you see this trend over the last couple of decades where the numbers of pertussis have shot up. Hey, guess what's happened in the past 2 decades? Oh, those granola crunchers decided that vaccines are of the devil. You know, yes, I can see you want to be a little wary of new vaccine technologies. But this is old, tried and true. We took the toxin, we boiled it, we chemically treated it till it's now pieces of the toxin, not the whole toxin. And has been around, I don't know, since the 40s, 50s we've been doing this. You know, Pasteur, Coke, they started this back in the 1800s. So this stuff's been around for a while. So I don't, other than granola crunchers thinking that's evil, there was a big thing going around back in the noughts. Oh no, don't get vaccinations because the vaccines have mercury in them. Well, it's like a minuscule amount of mercury, less than you get, or some heavy metal. I'm thinking it was mercury. It was used as a to maintain sterility. Okay, so anything that got into it, that mercury would kill it. But the thing is that what's in that vial had less of the metal than what you would get in a can of tuna. But they don't have a problem feeding their children tuna. Go figure. Diagnosis. Take a swab of the nasopharynx because they're coughing some of it up, so you can't get down to the lungs, but they're coughing some up. Some of it's moving up with the cellular escalator, so you got to get down in there. Swab that, and then you use what's called fluorescent antibodies. So pertussis doesn't have a distinctive shape like diphtheria does. So you have to use antibodies, because remember, antibodies bind specific pieces of proteins on the surface of a given bacterial species. So the antibodies stick. The antibodies have attached to them a fluorescent little probe. So you smear the bacteria, heat fix, add the antibodies, rinse away, and any bacteria that the antibodies, which are highly specific, stick to will glow in a fluorescent microscope. And you just look for glowing bacteria. No glowing bacteria, it's not pertussis. Of all the bacteria there, say only 0.1% of them glow green. Guess what? 0.1% of all the bacteria you got out of that swab of that throat specimen are pertussis. vaccine starts, remember I said around at 1-ish, and then there'll be, boosters, things like that. If somebody does get it, because either they didn't keep up with their vaccines and boosters, or their just immune system's just not quite there, antibiotics will get rid of the vegetative cell, and then you may have to come in with other things to get rid of any toxins or anything like that that may also accompany the bacterial infection. Because remember, easy to get rid of the vegetative cell, not so easy to get rid of any proteins or things that have been released by the bacteria.